Hi, welcome to today's episode of our Back Talk podcast. I'm Dr. Michele Perez.
And I'm Dr. Krystal Chambers. And today we're going to discuss differentiating between hip pain and low back pain.
So today we're going to talk about, we're going to call it the hip bone's connected to the backbone. So we're going to talk about a common issue that comes up in our specialty of trying to figure out the difference between a hip problem and a back problem, because those two things can really overlap in patients. They can have both things wrong. Sometimes it's one of the two and it's not really clear which one it is. So we're going to talk about some of the aspects of that. It's a challenge we have many days. And I know I get this a lot, and you probably do too, where the patients will end up with us and they have a hip problem because it's how it's described by the patient right to the schedulers sometimes. And so they end up in our office with a hip problem or vice versa in the hip doctor's office with a back problem. So we're kind of always going back and forth. But sometimes they come in and it's not really clear. So
that's exactly right.
Yeah. So
and sometimes they even have a hard time. Well, first of all, the patient can certainly tell you where their pain is located, but I often have a difficult time with them accepting that it's not their quote-unquote hip,
right,
and that it is their back. So the very first thing that I ask them to do before we get into all the back and forth of what's my hip and what's not my hip is, I said, put your finger on your pain. Point to where you hurt.
Right.
And show me that.
Exactly.
And
that's the easiest place to start.
Much easier to start there. And usually when that occurs and when they are truly in the right place and seeing the spine doctor for this problem, they're going to put their hand kind of on their upper butt or kind of the outside of the upper butt area. And they are shocked and surprised when they learn that that is not their hip.
Exactly. I'm always surprised how many people really don't truly know where their hip is, because they call what we would call the sacrum, that's where they call their hip, or the back of the buttock, they call that their hip. And I'm like, no, that's not your hip. We can say buttock in the world of medicine. So I say, no, that's your back or that's your buttock. And they're like really surprised to hear that. So yeah, you're right. I think just starting with point where it is and let's go from there. And then start asking all the questions about when does it hurt? Explain to me where it hurts. So talk about where the more classic places are that a hip will hurt. Explain that.
Yes. So when it's truly the hip joint where they're having their pain, I let them know that the pain is generally going to present in your groin. And again, because I don't want to get hung up on what do you call it, what do I call it, I'll put my hand on my groin and I say, if it is your hip, 9 times out of 10, you're going to hurt right here. And it's going to hurt when you flex your hip. It's going to hurt when you bend down to put your sock on. It might be hard for you to cross that leg over the opposite leg to tend to your feet or something like that. And
putting a shoe, a sock on is a big symptom, right?
Exactly.
Or having trouble doing
trying to sit with your legs crisscrossed on the floor. And so that kind of helps them to sort of start to differentiate, okay, that's my hip, something else is my back, coming from my back.
Right.
And then I once heard one of the orthopedists, or when the patient was actually trying to explain to me, when the orthopedic doctor was trying to explain to them, is that if it's, they kind of put their hand on the outside of their hip, kind of like where the bursa is. They said, if your pain is behind this, it's probably coming from your back. If your pain is in front of this, it's most likely coming from your hip.
Right.
The tricky part that we can get into, though, is if the pain begins to radiate. Or if it is just not sitting in that area and it's kind of drifting into the thigh, then you might have to start entertaining the notion that maybe both problems could exist in the same patient.
Right. So classically, it's going to be in the groin, sometimes in what we call the lateral hip or the outer side of the hip, but that's where some bursitis problems can come in. So we'll talk about the difference between arthritis and bursitis. The thigh, it starts to radiate down into the thigh. And knee pain's a big part of hip pain also. And I was actually taught by one of the orthopedists, one of the partners in the group, that sometimes patients will just come in with knee pain and be convinced it's their knee. And I actually learned that from him, that you really have to go look at the hip when they complain of their knee hurting because they're convinced it's their knee.
Exactly.
So that's something I learned many years ago that now I'm a little bit more in tune with. So,
Exactly.
So groin pain, thigh pain, knee pain, sometimes the outer hip, sometimes a little bit in the buttock, all of those can come together. You talked about some of the things that they're going to maybe say they can't do or complain of.
Right.
Or actions they can't do. So maybe should we define a couple of things that can go wrong with the hip? So arthritis.
Definitely arthritis is probably the main thing that can go wrong with the hip. But something else that I've been more sensitive to is these people or patients who have labral tears in their hip. And sometimes the symptoms don't quite fit into the lumbar category, and sometimes they don't necessarily fit nicely into the hip category.
Exactly. That's
so
where
you
it gets
really
tricky.
have to think about. It has to be on your radar screen.
Yes.
Once you kind of look over the things that are more likely. But then when those things don't add up, that's when I think you really have to kind of start to look outside of the box a little bit.
Yeah. So something I always think about with the difference between arthritis and bursitis. So arthritis is a condition of the joint where the cartilage wears out. So the hip is a ball and a socket joint. It sits, our pelvis meets with the leg bone to make the hip joint, the ball and socket joint, and the cartilage covering, will wear out, and that's arthritis. Bursitis, which is an inflammation of a structure on the outside of our hip, can get inflamed, and we call that bursitis. We have bursa in our shoulders, our hips, many places in our body. To me, one of the big differences between arthritis and bursitis symptoms is that patients with arthritis will feel worse the more they do, the more they walk, whereas bursitis, you kind of walk it off, right?
I would agree.
Right?
Yes.
They get up from a chair, you limp the first couple of steps, and then you feel better the more you walk. And bursitis is a much more minor problem, right? That's usually fixable through a minor injection or some therapy, whereas arthritis might be a little bit more complicated, longer term problem.
Exactly.
Yeah. So that to me, because so many people come in with bursitis who don't have any arthritis or have both.
Exactly.
Because you can have both.
Exactly.
Right.
And you do tend to see the bursitis picture pop up quite often in your lumbar spine patients, which I think has a lot to do with the weakness of some of the supporting musculature around that hip girdle, and then the tendons leading to where the muscles are attaching to bone start to take on added stressors, and then we get inflammation and bursitis and so forth.
Because all the muscles that make up the buttock area, those are called our gluteal muscles, right? So we have several gluteal muscles. The big one called the gluteus maximus, which everybody's heard about, that makes up kind of the bulk of the backside. And then we have the smaller muscles along the outside called the gluteus medius and minimus. And those all wrap around to the side of our hip on the outside where that bursa is.
Exactly.
And so can cause a bursitis, or sometimes, to your point, it's just a weakness there that's pulling and tugging on that and causing inflammation. So I'm sure you see tons of patients who have gluteal tendinitis, which seems like bursitis on first look, but it's really a little deeper than that, and that's more of a deep tendon problem. Right?
Exactly.
So, and then you brought up the labrum. So explain that a little bit.
So the labrum is part of the cartilage structure inside of the hip joint, and it can exhibit signs of wear just like any other ball and socket joint throughout the body. But some of our patients will develop tears in these pieces of cartilage, and it's quite painful. And can produce a lot of disability for them.
Right, yeah. And that's a little harder to diagnose because, like you said, their symptoms might be a little bit more vague. I know one of the things that is often talked about is patients will often, instead of pointing to their hip, they'll use the letter C and they'll kind of grab the outside of their hip and say it just kind of hurts deep.
They'll say it's
in
a deep
here. It's
inside.
Deep. It's a different pain. It's
inside.
gnawing.
Yes.
They don't necessarily lose range of motion.
Correct.
They might be younger, right? They might be really active and a little bit younger. Arthritis might strike someone who's a bit older. And like you said, it's usually from wear and tear, but a lot of times from previous sports activities, runners,
exactly.
people who are doing CrossFit, things that are really kind of putting a lot of stress on the hip. Right. So their symptoms are a little bit more vague. They still have range of motion, but they just can't describe. It's just this
very
deep
hard
pain.
for them to put their finger on that.
Right.
Yeah.
So we can easily diagnose arthritis on an X-ray, right?
Yes.
So we see narrowing of the joint on the X-ray, but then all those other things become a little bit more difficult, more of a clinical diagnosis. And then the labral tears need a special test to diagnose.
And those need to have MRI scan with contrast.
Right. That's called the MRI arthrogram. Right.
Exactly. To really nail down that diagnosis. But once again, it has to be on your radar screen,
right?
To even think to do that, because the more common reason for the hip joint itself to hurt is for that hip to be arthritic. And that's very easily diagnosed with an X-ray. Many times patients think they need the fancy test, but many times you do not need the fancy test.
And that's a great point, because some patients will automatically feel like they need an MRI on their hip because we're so used to ordering MRIs on shoulders and spines.
Any other body part.
It's ubiquitous in the spine. But once you make the diagnosis of arthritis on an X-ray, you've clinched the diagnosis.
You have clinched the diagnosis.
Doesn't matter if you have a labral tear or not. The labral tear has partially led to the wear and tear of the joint, which has led to the arthritis. So you're past diagnosing the labral tear or fixing the labrum because you're now just to the point of needing the arthritis to be addressed.
Hip.
Right.
Exactly.
So, so should we talk about
let me just talk about this too. And you've probably seen this in your practice. When these patients when they truly do have the arthritic hip, and so they may have decreased range of motion with external rotations. That's when they rotate their leg outward. And they just don't have good range there. Or when they walk and they're in their stride, they don't have good extension of their hip. And then they start to hurt in the SI joint region.
Right, okay.
And so this is in the low part of the back, in the lower back where it meets the buttock, kind of at the base of the spine. And sometimes I feel that some of these patients have maybe some irritation of their sacroiliac joint just because they don't have adequate range of motion of their hip when they're going about doing activities.
Stressing out that
and they stress out this other area.
Yeah, because I'll explain to patients our pelvis is like a pretzel, right? That's how we always describe it. So if the front part is stressed or painful, the back part too, because it's a ring. So it can be stressed. So that's something important to bring up, is sometimes it is difficult to tell which thing is hurting the SI joint or the the
which one is the
joint
cause,
or the hip
which
joint.
one is, yes.
Right. And so I guess we could talk about how do we sometimes figure that out. So we can get an X-ray and prove that there's arthritis. That's pretty easy. Then we have to have a conversation about how do you treat that?
Right.
Maybe we should bring up, so I don't want to get too far into this because we're going to probably talk about with a lumbar problem, if we don't know if it's lumbar or hip, why do we use an injection sometimes? So maybe let's save that. But so let's talk about the treatments for arthritis in the hip.
Okay.
Not too many, right?
Not too many.
Yeah, it's pretty straightforward.
But exactly. And so, I'll always have patients get some physical therapy. I clearly let them know, I don't know how much of your range of motion we'll be able to restore, but you still need to go through these motions and you still need to exercise these muscles. So they will
stronger,
have
like a prehab kind of thing, right? Like a knee.
Exactly. So they will go through that and they'll learn what they need to do. But if the pain is really debilitating for them, or it's keeping them from doing exercises or doing their activities that they enjoy, then the hip can be injected under X-ray guidance with corticosteroid.
Right.
And just depending upon how much relief you're able to get with that, then that would dictate whether or not this is a reasonable way to manage until or unless you're ready for a hip joint replacement.
Right, which is the ultimate treatment for joint arthritis, especially of the hip, is a hip joint replacement. And going back to the injections, those can last anywhere from 3 months to a year, depending on how severe the arthritis is. And they might start to wane in their effectiveness, right? So
Right.
I try to advise patients that this may work at first, but as time goes on,
we will probably get diminishing return because the joint is going to continue to deteriorate
with time.
And it just
not anybody's fault,
right?
It just
what
it's
it
not
does.
your fault.
Just what it does.
It's what it does.
Right.
So,
joint. And I do. Do you put the patients in the water sometimes for their arthritic hip?
If they want to, yeah, absolutely, yeah. I think some patients are a little resistant to water therapy for a variety of reasons, but water therapy is great for a whole lot of.
I like to at least offer it.
Yeah,
you have some that they hear it and they just pick up that ball and they just want to run with it, and then you have others for, like you said, a variety of reasons. They're not getting in the water. They don't want to put on a swimsuit. All these things, but that is something that I will, try to offer them sometimes.
Yeah, because you're taking the load off the joint when you're in the water, so and it's easier sometimes than land-based therapy.
Exactly.
So joint. The only other injections we could really talk about, which are not used very commonly, is like hyaluronic acid, and people know them as the rooster cone shots.
The rooster cone shots.
But those are not FDA approved for the hip joint, only for the knee.
Right.
You can safely do it, but it's considered off-label, so I don't do it. But if somebody asked me to, I would. It's perfectly safe.
Right. And that's the conversation that I'll have with them if they ask. But no, I don't do it either.
Yeah. And then we have PRP.
We have PRP.
Platelet-rich plasma, which is a product where we take patient's blood and we take out the red blood cells out of it through a process in a centrifuge, and we get the plasma left over, which has all the good stuff in it, all the platelets and the anti-inflammatory properties, and we can inject that into a joint. Again, not an approved procedure by insurance in our country.
Correct.
So, but we can do it, and it's perfectly
something
safe.
that we offer,
and we can do it
the
for
one
you.
Who wants to proceed.
And does it work any better than corticosteroids? Nobody knows.
Nobody knows.
Right? So.
Right.
And then there's a joint replacement, which we have very many talented surgeons in our group who do joint replacements, who can replace your hip joint with artificial joint. And
when you're ready,
and you'll be very well after it's all said and done.
Yes.
So let's see. And then back to the last thing about the labral tear is those can also be repaired surgically.
That's
That's a little bit more complicated, I guess. It requires a surgeon. Not all surgeons perform that kind of surgery.
Right. So that's the arthroscopic procedures.
Right.
But yes, not all surgeons will perform those, but it is an option out there.
Yeah, to repair it in the hopes that maybe if you repair it earlier, you might slow down some of the progression. Right. So that's the main reason a younger person would maybe choose to have a labral repair surgically, although it is a little bit, it's a bit of a recovery, right? Because they have to be non-weight bearing for a while. I'm speaking a little bit outside of my expertise.
Exactly.
But our area of expertise. But
and I agree with you there, but I have had a handful of patients who opted to go that route, and the recovery, it wasn't easy.
Yeah.
It was not.
Right. So I guess we could talk now about lumbar and how that sometimes gets confused with a hip problem. So why don't you start with that and explain that?
Like we started off saying, the first order of business is show me where your pain is located. And so once we have established that it is more likely than not lumbar and not in the hip, then that's when we'll proceed with doing our physical examination, of course, and a basic set of lumbar spine x-rays to determine if there's any degenerative changes, misalignments, bone spurring, arthritic changes, and so forth, and disc space narrowing. And so from that, we can usually outline a nice conservative care approach, treating them with physical therapy, anti-inflammatories, activity modification. I say modification because there's usually always some things that you can still do, but there are some things that you can limit or avoid just to minimize any exacerbation of the pain that's there.
Right.
And so it's a lot easier when the lumbar pain extends on down through the leg because there's not really many things that will do that other than the lumbar spine.
Right.
But when the pain just kind of hangs out in the lumbar and just kind of up in that upper buttock or lateral buttock area, then that, can open the door for several different etiologies for why that pain is there, whether it be coming from a disc, whether it comes from one of the small joints in the back, a combination of those things, the sacroiliac joint. So that's when we need to spend our time trying to kind of differentiate those diagnoses.
Yeah, I think the place where it most often the two seem to overlap or where we have to use a lot of skills to figure whether it's hip or back is where we get compression of what we call the L2 or the L3 or even the L4 nerve roots. So these are roots in what we call spinal nerves in our spine that extend into. So the root people always talk about is the sciatic nerve, but that's not the only one that goes into our leg. We have multiple roots that go into different parts of our leg, and the L2, L3, and L4 nerve roots reach into the front of the thigh. And into the knee. And so this is why sometimes hip pain and back pain or nerve pain from the back can get confusing on examination or even testing. So that's where physical exam comes in, and sometimes diagnostic testing, which we can talk about. And sometimes just one other symptom that might not be present with a hip would be numbness and tingling.
That is right.
Because with a nerve root problem in the spine, where there's a pinched nerve, not the other stuff you were talking about, like the small joints in the back, which are not going to necessarily extend into the leg. But a pinched nerve is also, often patients are going to talk about numbness and tingling in their leg, which won't be present with the hip or should not be.
With the hip problem, it shouldn't be,
So that's where you sometimes can get a clue, And then if we think it's lumbar, we almost always do get an MRI of the lumbar spine, And the hip is not always the case, but the lumbar area, we need an MRI most of the time because we can't see all those soft tissues, the discs, the nerves.
Correct.
So, and that sometimes that helps and sometimes that doesn't, right? Because then sometimes what happens? You have a back with problems at L3 and L4. You have arthritis in the back. You have hip arthritis. And then which is it? Is it both? I just went through this with a patient.
Exactly.
If he's listening, he's going to be like, yeah, I know, we just went through all this. It was a long journey of trying to figure it out. And how would you say, other than history taking, exam, diagnostic testing, what's next? What do you do to try to figure it out?
Yes. So once we've gone through those things, then very often we've gotten our MRI scan. Then at that point, injections can kind of point you in one direction or the other. Sometimes it actually points you in both directions.
Exactly. Because you can have more than one problem.
That is
I sometimes tell patients, you don't always have just one problem in orthopedics. You're allowed to have more than one.
That's right.
It's not fun.
That's right.
So the reason for the injections is diagnostic and therapeutic, right?
As well as therapeutic.
There's power in the diagnosis after you have an injection. If you get no relief at all, that sometimes muddies the waters.
That is right.
But if it's positive response, it helps guide us, even if it's not long term. It still helps guide us.
It helps you to understand which problem is the more predominant problem. Because you do have those patients where that hip is really arthritic. They also have really bad nerve compression in their spine. And so you may be able to manage them for a period of time with those injections. And I've had patients where we'll inject their hip, we'll bring them back a couple weeks later, we'll inject the lumbar spine, and they get a different kind of relief out of each injection. So that helps you to understand that both problems are symptomatic.
Correct.
Which one is
taking precedence? Which one's interfering with their daily activities?
Is
speaking to them. That's a good way to put it.
Yeah. Exactly. And
sometimes hip arthritis is not symptomatic.
This is true.
Right?
This is true.
You can get a hip x-ray and be shocked by how badly arthritic the joint is, and they don't have any symptoms.
Right. And to your point, I had a lady like that just yesterday, and her hip looks horrible. But she's got L2-3-4 pathology in her spine.
Right.
And so we're focused on that. And the only problem with that arthritic hip is that she can't sit crisscrossed with her legs crisscrossed. She's like, and she said, I don't care that I can't sit with my leg crisscrossed like that.
That's
she said, the back is speaking to me the loudest.
Yeah, right.
You know, and so that's where we're focusing our treatment.
Right, because just because it looks bad on an X-ray or an MRI or whatever it is, if it's not symptomatic, you just notate it. We talk about it, and we'll deal with that if the time comes that it becomes a problem. Because you don't want, you're not going to have a surgery for something that is not currently interfering with your activities or causing
and your
pain.
Quality of life.
Correct.
Exactly.
Yeah.
And the flip side of that is unfortunately, you have the person where both problems are really bothering them tremendously. And they've done the conservative care. They've done all the shots. They've done all the exercises. And there they are. And in those instances, we've decided to fix the hip first. You can get a hip surgery and recover from that
really quickly,
much more quickly than the same on the lumbar spine.
8 weeks,
and some
10
folks,
weeks.
We've been able to stop there.
Right. Because
we've been able to stop
their back
there.
will feel better.
Back will feel better because
After their
they're
hip is
walking
done.
better, they're moving better, they're able to exercise better, and all of these things have fallen into place for them.
Right, because you can recover from a hip joint replacement in 6 weeks.
That's right.
People are, surprised
Raring to go.
Surprised to hear that. Yeah. So, can you think of anything else?
Well, we briefly touched on the sacroiliac joint earlier on,
right?
And if that is felt, it's a much less common reason to have pain.
So let's define sacroiliac joint for everybody.
Yep. So the sacroiliac joint, if you can imagine where the base of your spine meets the one half of your pelvis, where those two structures come together, is a joint that runs straight up and down in the buttock. And that
we have two of them.
And we
one
have
on
two
the right
of them.
and one on the left.
Yep. And those we call those sacroiliac joints. So there are some folks that believe that there's really not much movement that takes place at that joint at all.
Or that there's not much that can go wrong with it.
Exactly.
Which is untrue.
But we know, those of us who treat these patients day in and day out, we know that when neighboring structures go bad or they're fused, have fusions in their spines and so forth, and they're impaired mobility of joints that are supposed to move, now they don't move. Well, those stressors have to be distributed someplace else.
Correct.
And so the SI joint can absorb some of those stressors and get overworked and become painful.
Right.
And so really the only way to diagnose pain coming from that joint is to inject it.
Right. That's a super challenging diagnosis, right?
It is.
Because it's not so... It's the pain can be very vague, just like the other hip stuff we were talking about. It can be very vague, and it's often confused with back pain, but it's really more pelvic pain. So, like you said, there's no really good imaging test, right? There's no true gold standard imaging test for the sacroiliac joint. So if you've ruled out your hip and you've ruled out your back, you might need to go inject the sacroiliac joint for diagnostic reasons.
And just like you stated earlier, you can get x-rays of it, and you can have all types of sclerosis and arthritic changes, and that joint is not always painful for everybody when those changes appear. So again, we have to evaluate that in context as well.
Right. So it boils down to a lot of listening, right? A lot of, pointing out where it hurts. Because that pain diagram doesn't always work.
The pain diagram is so extremely difficult to follow,
so just point where it hurts. Oh my gosh, doing a physical exam, right? Just do a physical exam.
Exactly.
Because I always tell patients, they ask me, is it my hip? And I'll tell you in about 1 second if it's your hip. And all I have to do is lay you down, move your hip joint, and we know.
And wait for you to react or not.
You will not like me if I turn your arthritic joint the wrong way. But if you don't have an arthritic joint, you can turn that hip all day long, and it doesn't hurt at all. So that's really important. all of orthopedics, physical exams so important. And then, the scans will come in sometimes depending on the diagnosis and come into play. And then the injections, finally sometimes are useful to tease out some of the more complicated cases.
And giving you diagnostic as well as therapeutic info.
Right.
Yep.
Yep. Okay.
Yeah.
Well, I think that covers it.
All right.
Yep. All right. Well, thank you for joining us for this episode of Back Talk.